So I think we have a pretty good quorum, and I know people's time is valuable, and so I will get started. We'll be joined by Jen Specht a little bit later, who's the person who's been running these reviews, and also Will Gwynn is the other person who will present his perspectives today. He is in clinic, as am I, so we're sort of tag teaming it, but he is wrapping up a visit with a patient and will join us when he can. So to round this out on the other half of the hour. So I think everybody knows me, but I'm Tasha Hunter. I'm one of the breast oncologists and had the privilege to go to San Antonio this past year. And so I'll talk a little bit about the things that stood out to me as being practice changing and important new research to review. So I don't have anything to disclose. So today, I know that everybody's learned about HER2 low disease. Can everybody hear me okay?
Yeah.
Yes. Awesome. Okay. Everybody's been talking about HER2 low disease, and I was thinking that I would probably go after Will, but so I'm saying even more talk about HER2 low because will be talking about the Destiny trials, which I think were the really prominent takeaways from the San Antonio conference this past year. Everybody was thinking about HER2 and talking about HER2 low and its impact in both HER2 positive, but also, but more importantly, in the ER positive HER2 classically negative population. So I'm going to talk a little bit about HER2 low and its and some of the pathologic implications that we learned about in San Antonio. Hannah talked during the first review session before the new year about some of the new data that's come out in terms of metastatic estrogen receptor positive disease. I just wanted to, I thought that there was an interesting little review that I thought I would share with you in terms of kind of incorporating this into practice. And then I have a couple of posters, certainly, if there's time to look at. I'll go over posters, a few posters from our group, and then just a couple of posters that caught my eye that I thought were interesting. So, and I'm hoping that these slides are not filled with mistakes because I did them kind of on the fly. But so HER2 low, I think that the main question that kept coming up throughout the conference was, how do we define it? Is it real? Is it just an artifact of the fact that HER2 seems to have some impact on the classically HER2 negative population? So how do we define it? What are we actually meaning when we talk about it? So what does seem to be a fact is that patients with HER2 low disease appear to derive benefit from trastuzumab deruxtecan. However, the question is, how low is too low? How high does HER2 expression have to be to derive clinical benefit from HER2 or the other targeted antibody drug conjugates that are being developed? Can we rely on the historical biopsies for HER2 low determination, especially since whether disease is 1+ or 2+ or 0 to 1+, that hasn't, certainly whether something is 0 or 1+ hasn't been clinically relevant to our practice. And so, and HER2 has been complicated enough to sort out in the past. I don't know if Mark Kilgore is here or any of our other pathology colleagues, but HER2 low has been a thorn in everyone's side, or HER2 determination has been a thorn in everyone's side. And even after the 2018 ASCO CAP guidelines were released, I think it's been challenging. And so, and then the question is HER2 low status. Does it stay stable? Does it, does it change over time? And so all of these questions were bouncing around the conference. And I think that there were a number of studies that I'll highlight today, and more also that I won't highlight today that address some of those questions. So going to the question of can we rely on historical biopsies? A couple of studies address this question, and the answer is probably. Pathologists do seem to agree with the historical biopsies that they're looking at mostly. And so in the Destiny Breast 04 data that we'll talk about the clinical aspects of this, but there was a study looking at comparing historical determinations of HER2 status with central review, contemporary or current central review of those biopsies, and whether there was agreement between those biopsies. And there was 78% concordance between those historical determinations and the central assessment by the pathologists in the Destiny 04 trial. And then among the 22 discordant samples, 88% were centrally scored, in other words, scored in current times as IHC 0. And then another 12% were scored as IHC 2+ or 3+. So here, I don't know if you can see my cursor, but this is the kind of relevant concordance area. But and so take that as you may. So 78% by some standards is, it kind of depends on your perspective. There were a couple of other trials that seemed to reflect those same results. One by Viale, which did a multi-center study with 13 sites in 10 countries. And they found concordance, almost 90% concordance between historical and rescored HER2 assessments. And then a third one by Rushtoff with 80 pathologists from 65 labs found greater than 80% concordance. I actually saw a reference to another trial where there was closer to 60% concordance, but it's somewhere in the north of 50%, probably 80-ish%, 70 to 80% concordance. They always do a little review at the very end, sort of what are we going to do on Monday morning? So they go through the whole conference, and then on one of the last days, there's a Monday morning plans session panel discussion where they talk about practice changes and what we actually expect to see, and what's relevant in terms of what we've seen in the conference. And one person who was looking at some of these pathology results, her quote was that these data demonstrates pathologists' ability to achieve acceptable levels of accuracy for identifying HER2 low patients using the current assays when the 2018 criteria are followed. I mean, that's an interpretation. I don't have a strong opinion, but I think that there is a question. Is it acceptable? Is 80% accuracy acceptable in order to rely on these historical biopsies, or do we need to actually re-review all of our biopsies when it becomes a question of whether we're going to treat with TDXD? So that's at least the data that we have right now in terms of what the historical biopsies, how they compare to how we're looking at how pathologists score them now. So I think that's one relevant question. The other question of does it stay low? So if it's HER2 low, is it always HER2 low? And there were a couple of interesting studies. The most interesting one I think that I saw was an autopsy study by Gukens et al. And they looked at 10 patients who had died from HER2 non-amplified metastatic breast cancer. And they looked at 13 to 16 samples per patient. They looked at all of their metastatic lesions and then multiple lesions sometimes within those organs. And they compared all of those lesions from different sites and then intra-site as well. And so I found this to be very interesting. So you have all of these patients at the bottom. This is the key here. And so one of them actually had, frankly, HER2 positive, so IHC positive disease. But in many of them, they had HER2 2+ disease. They had a whole range of findings, which I thought was striking. But even more perhaps striking than that was that there was actually intra-organ heterogeneity of HER2 status. So they looked at different sites within, for example, the liver here, and found all sorts of heterogeneity, even within one organ. They found that tumors displayed a range of HER2, of what we would call HER2 statuses. So it seems to be sort of a spectrum, even within the tumor in a given organ. And then finally, the distribution per organ is also strikingly heterogeneous. So there's no clear pattern of HER2 status according to organs. And so this is broken down, this P remains the same, but this is broken down in terms of the distribution of HER2 status that we see in the various organs. And so there seems to be heterogeneity between organs, within organs. It all seems to be somewhat heterogeneous, which raises the question of, can you rely on a single biopsy of a single site to determine HER2 status? So that was the question of tumor location, but then there's also the question of change over time. Or I should say, the status of HER2 in a given time point in various locations, but here is over time. If you do have a tumor that has, that you've determined or you've called given a certain status, does it stay there? And there were a number of studies that looked at this in a variety of ways. This, I thought, was the most striking one, was Dankert et al. Looking at the data from the Penelope B trial, which I'll remind you was 1,200 patients that were randomized to post-neoadjuvant palbo versus placebo. And so they took pre-therapeutic biopsies, so before the patient started chemotherapy, and then post-therapeutic residual tumors. So if the patient did not achieve a pathologic complete response, they were able to look at their tumor afterwards and compare the HER2 status of those two biopsies, or two tissue samples. And interestingly, as you can see here, there was significant crossover. So largely the tumors remained the same, but 22.7% of patients who were HER2 low went to HER2 zero, and 14% of patients who had been HER2 zero on their biopsy went to HER2 low in their residual disease. And not only that, but it was associated with some prognostic differences in the retrospective analysis. So they looked at the survival curves of those patients stratified by whether they had changed or not. And there was no prognostic difference for the folks who went from HER2 low to HER2 zero, but interestingly, there was a reduced or a worsened prognosis for people who had gone from HER2 zero to HER2 low, and it suggests that there is some evolution of the tumor based on the pressure, the pressure that's exerted through the chemotherapy or the treatment that they're receiving, and so that maybe the tumor is finding a kind of escape pathway or a new growth pathway. So I thought that was super interesting. There were also a couple of other trials that had similar structures and showed a pretty similar rate of change from HER2 zero in both directions, I should say. So at that same wrap-up session where, what are we going to do on Monday morning, one of the oncologists, one of the attendants, came up to the microphone and said this quote. She said, "I worry that the clinical validity of HER2 low itself is seriously in question. Is the trick that you try to get your favorite pathologist to call something HER2 1+." And I think that, it sounds a little cynical, but I think that is the question that many of us were kind of thinking about. I think that we have, like I say, I don't know if Mark's here. I don't have the list of attendants right now, but Mark or Susie or Rebecca, any of our favorite breast pathologists, we're calling them and asking them, is it is this really HER2-0, or could you squint at it and call it something different? And so, and that's not really, I don't think, how most of us want to practice medicine. We want
right, but Todd, so none of them are here, but I'm going to channel them. And what they're going to say is that there's no difference between 0 and 1. They've said that
right.
repeatedly to us. So it's not about calling your favorite pathologist. It's not really, it's not real.
Well, I think
0 people are positive, and that's the answer. And
I
so
think that's
they
what
are
the
going to
take-home
call
message
it positive.
is. Yeah.
But it's
I think
not
that
about
is
manipulating the data. It's that the data shows that there are these HER2 high, and there are the other people, and the other people benefit. And now the insurers have pushed us into this, but obviously we just don't know. I mean,
exactly.
you know, there's something that we're not measuring.
Well, I think that's what these studies really support, is that this is a dynamic process. Wherever it depends on where you look, it depends on when you look, and so really, I don't know that we need to know the answer, and I think that's the conclusion that I came to. I mean, I don't know. It sounds like you come to the same conclusion.
Yeah, I think we're just in a funny place with this, and now we have to go back to the beginning and figure out what the biomarker is and what to measure. And so I know the TBCRC is contemplating a registry study, and I applaud that. I think everybody now is sort of having a different religion about it. And if you're at Yale, you think that David Rim is right. And I'm not saying he's wrong, but we don't know that that's right. It took us so long to get to the HER2 place. So what I would say is just an even more primitive statement, which is, this is good chemotherapy for breast cancer.
Just give it to everybody. Yeah. So one last thing about trastuzumab deruxtecan, and then I will let Will take over from me and talk about the Destiny trials. But there was this TRIO trial, which was Hurvitz and Bardia looking at, it was an investigator-initiated trial to look at the addition, or look at trastuzumab deruxtecan for HER2 positive, hormone receptor positive, HER2 low, early stage breast cancer, and whether, and also whether the addition of endocrine therapy to trastuzumab deruxtecan could enhance the effect. They were looking at it neoadjuvantly with the primary objective being pathologic complete response. 58 participants. This was not a trial where they're comparing to any other neoadjuvant therapy. They're actually just comparing TDXD to TDXD plus anastrozole, and actually there wasn't any really formal statistical comparison. So this is an exploratory trial, and it's not finished yet. As of the data cutoff, there's surgical outcomes that are still pending in about a quarter of the patients. At first glance, this is an overall response rate. At first glance, it looks similar to the waterfall plots that we've seen for TDXD and in metastatic disease. That said, only about 15% of patients have achieved a 5%. Have achieved PCR, which is probably comparable to the PCR achieved in estrogen receptor positive disease overall. But it will be interesting to see what the results of this study turn out to be once they've actually analyzed all the surgical data or the pathologic data. And it's certainly, at least in terms of the tolerability profile, it actually has been quite tolerable for patients. So will be interesting to see where this goes, but it's certainly not practice changing with 58 patients, but it's certainly an interesting direction that people are going in. Changing gears a little bit away finally from Enhertu, the TROPiCS-2 study presented by Hope Rugo, looking at sacituzumab in hormone receptor positive metastatic breast cancer. This was a population of patients who were pre-treated. They progressed after endocrine therapy, a taxane, and a CDK4/6 inhibitor in any setting, or between 2 and 4 lines of chemotherapy in metastatic disease. And they were randomized to sacituzumab or physician's choice with a primary endpoint of progression-free survival. And the sacituzumab showed a statistically significant benefit in progression-free survival. over physician's choice. So, and the other question that Tropics was looking to answer was, does it matter what your TROP2 expression is? This was centrally assessed, and they stratified it according to the H score, which is it's basically a score based on the percent and intensity of IHC staining. And the long story short, there didn't seem to be any differential effect that correlated to their H score. So essentially, this was an effective medication across all levels of TROP2 expression. So this is not something, maybe in the future there might be a different biomarker that might better stratify patients, but for now, it's something that we could consider giving our estrogen receptor positive patients in later lines. Hannah talked on during our last review session, keeping an eye on the time here, about the recent data for progression after CDK4/6 inhibition. So I'll just remind you, I don't want to rehash everything that she said with in much more detail. But just to remind you, the Capitello trial looking at capivasertib, an AKT inhibitor for patients who are either mutant or wild type. So for all patients after progression in CDK4/6 inhibitor that did show a favorable response, there's the question of SERD monotherapy, so camizestrant or elacestrant. The PACE trial was reviewed looking at Palbo, basically Palbo after Palbo trial that didn't improve. That was presented at this past conference, and Hannah reviewed it at the last meeting. And I am going somewhere with this because I did think this was useful. I would remind you that the MAINTAIN trial from ASCO 2022, so a few months ago, or 6 months ago, did look at patients who had progressed on endocrine therapy and assigned either endocrine therapy switch, so a switch of whatever backbone endocrine therapy they were on plus ribociclib versus that same switch plus placebo. And they did find a significant improvement in progression-free survival in the patients in the ribociclib group. So there was a discussion for what does this actually mean for us in terms of what we do for patients who progress on CDK4/6 inhibitors. And I thought that this little graphic or cartoon that Sarah Tolaney and Tanya Fame put together as a kind of proposal for how we would approach patients who had progressed on these agents. I thought this was at least an interesting conversation piece, and something that I am going to think about in terms of my practice. So it's kind of a little decision tree. So if patients have BRCA mutations, then obviously a PARP inhibitor is something that we would think about, although no overall survival benefit has yet been uncovered there. For PIK3CA mutated patients, you can think about alpelisib and fulvestrant, but for those who are not mutated, you can think about capivasertib in those patients. The elacestrant, the oral SERDs are something that we can think about switching to. There did seem to be some evidence of progression-free survival benefit in the trial that I haven't mentioned. Changing those patients over when we do detect an ESR1 mutation, although ESR1 is another one of those biomarkers that we think is probably dynamic, but certainly elacestrant and the other oral SERDs are something that we can think about in those patients. And then in terms of the MAINTAIN trial, we can think about switching that endocrine backbone and adding ribociclib. If there is, and their thought was if there's mild progression. So you wouldn't want, if the patient does seem to have galloping disease, you wouldn't want to just switch the endocrine backbone and switch the CDK4/6 inhibitors, but that double switch does seem to have some efficacy. I think that that's worth considering in the world where I think more and more of us are starting ribociclib first line for patients. So I don't know how that affects our treatment algorithm. Everolimus and endocrine therapy, AI or fulvestrant are still options for us. And then obviously if someone is in visceral crisis or facing imminent organ failure, chemotherapy is the option. Someone has put something in the chat.
Hey, I'll just tell you what I said. So I think this is interesting, but there's something hugely missing here, which is how long did they benefit from the therapy? Was it 5 minutes or 5 years? And I think there's a huge difference for somebody who rapidly progressed on an AI CDK4/6 inhibitor rather than had a huge and durable response, which is the usual response. So I completely disagree, sorry, that you might get the chemotherapy out before they have imminent organ failure. We all know that we've used chemotherapy judiciously, not overly toxically, for patients. And unfortunately, every ER-positive patient does not benefit from endocrine therapy, and we know that. So we have a study right in that niche, right where that little blue arrow is, using FES PET to help you make that decision. You can't do it if they're on tamoxifen or fulvestrant, but you can do it if they're on the AI CDK4/6, which most people are. And I think you just gotta, it's nice that there's the maintained data. I agree, but it could be a BEMA. It could be switching from ribo to palbo. We don't know that. But I do think that what we learned at San Antonio is switching the endocrine part alone is going to be pretty useless. But I think where we're at is that we've got a lot of dance partners for the endocrine therapy to consider. And I agree that all these things are things to think about, but the alpelisib and capivasertib are exceedingly toxic, likely much more toxic than any of the chemo you tend to get. So I think this is a little skewed. I understand how we got to this chart, but it isn't how I present it because I think it's a little bit, based on what the companies want us to say rather than what we really do. Capecitabine, PDXD, and weekly paclitaxel or vinorelbine are very active regimens that are a lot cheaper. And I understand it's annoying to the patient to get infusions and to have to come in a lot, but I just feel like this kind of looks weird. And it's like, oh, maybe right before they die, give them the chemotherapy. And that just, yeah, I'm sorry. I don't mean to be difficult, but
this is not my chart. I mean, I just thought it was an interesting, I think it's an interesting conversation piece. I think we're all wondering how to order these therapies and what to do when and where, and I think that, like you say, for example, I would be pretty hesitant, especially, there are many areas here where I would be hesitant to use the therapy that's listed rather than capecitabine, because capecitabine is so effective. And even though technically it's chemotherapy, it's just not, it's probably less toxic than a number of these therapies. So.
And Tasha and Hannah, I hear you and I agree in some circumstances, although I will, just to play devil's advocate, I mean, I frequently would go to capecitabine, but then I would find myself then in later lines realizing that I had kind of given up on endocrine therapy maybe too early, and that I had not offered a line of therapy that maybe could have worked. And so I think that
but Rachel, you don't have to give up on it early. You could give capecitabine and then you could go back to endocrine therapy. I don't believe that once you make the switch to chemotherapy, it's an infinite direction. So that we don't have, this is a data-free zone. And it may be that what really is going on here is you've exhausted endocrine sensitivity. And if you give them a break and give them a different type of therapy, they may resume endocrine sensitivity. We don't know any of this. And so I'm just saying that I think it's wrong to jump to conclusions based on a couple studies in novel targets.
I accept that. I do think that the other piece I'll say is just that the alpelisib, although very toxic, does have overall survival benefit, and it's hard to ignore that. And I feel like that's one of the places that we really struggle, because if somebody has a PIK3CA mutation and they can tolerate it, it can be a great drug. But I agree, it's very toxic, and it is hard to want to pull that trigger after they've done so great on letrozole and palbo for so long, and then you're like, oh, am I really going to give them alpelisib instead of CAPE?
Right, and it may be
Sure.
that if you give them abemaciclib with their PI3 kinase mutation, or ribociclib if they started on palbo, that they might do just as well for a while. But I agree, you don't
For a
want to miss an
while.
opportunity to give alpelisib, yet
Right.
that drug is highly problematic. No, I just think what we want to do is be very humble about
Effective
what the
versus-
limits of the data that we have. And, you know, we have a study for FES to help you at this juncture. And that might be helpful to make a decision about whether you want to keep giving endocrine therapy if they're functionally not endocrine sensitive by imaging. That might be a hint.
As I said, a good conversation piece. So I think that I think we'll continue to talk about all of this. But as you say, I mean, I think the data at this point is limited. So I know that Will has joined us, and I want to give him plenty of time. I just wanted to give you a quick look at a couple of posters I thought were interesting, and then a couple of posters from our group, and then step aside. So, and I'm not highlighting any particular part of these posters because I knew that we would have limited time, but here's one that caught my eye, and I chatted with this person at the poster session. This was a poster from a German group looking at the number of involved organs at baseline, and they found that this was prognostic for overall survival in patients with MBC. Why is this interesting to me? I mean, it's a little bit intuitive, but what they found was that the more organs that were involved and the more visceral sites that were involved, the poorer the patient's prognosis is. And it's not directly relevant to a question that I've been having, but I've encountered a couple, 2 or 3 patients recently where I've taken them through, years of surveillance, and then close to the time that the surveillance wraps up, they present with pretty overwhelming disease, just kind of off the bat. And they have been asking me, why are we not scanning? And they've been asymptomatic and feeling fine. But then all of a sudden, over the course of a week or 2, they have shortness of breath, and they wind up having big pleural effusions and liver involvement. And I realize that these are kind of, but maybe one-off patients, but I've had a number of them, and I know that Hannah has too, had a few of them. And the patients turn to you and they're like, "Why weren't you scanning? Why?" And telling them, well, the data shows that it really doesn't matter, and the survival is the same, regardless of whether we're looking for metastatic disease or not. I still believe that to be true, but I struggle with the fact that some of these patients have high risk disease, and should we be trying to catch metastatic disease earlier? Would they do better? And what would that look like? So I don't have great ideas about that currently, but it's sort of something that's on my mind. And this was one of the posters that I saw that kind of supported that. So the other was thinking about HER2. There's a lot of these. This is an example of one of a number of these kinds of technologies that are in progress. But this is an automated AI system for reproducing, for diagnosing HER2 and assessing HER2 IHC scoring. So I am wondering if that's what's in our future in terms of pathologic assessment of HER2, along with other, potentially even other pathologic features. But obviously HER2 is the one that's on our minds most prominently right now. So I thought this was an interesting poster, but it also is representative of a number of posters that were at the conference proposing various techniques. Our poster was, and I know Linnell is here, our poster was looking at FES, and I really am going to wrap up, looking at FES and PET, FES PET and FDG PET imaging in patients comparing HER2 positive and HER2 negative metastatic breast cancer. And what we found was that, interestingly, there was not a significant difference in FES activity within those separate patient populations. That even within the HER2 positive patient population, where we really think that HER2 is the driving pathway, the endocrine pathway appeared to be very active, and it remained active over time in scans. We had, it was 8 scans that showed that we were able to plot over time, where they had multiple scans, paired scans over 2 or 3 time points. And FES remained stable even as they were treated with endocrine therapy and HER2-directed therapy, which we thought was very interesting. I don't know, Hannah or Linnell, if you wanted to add anything on that front.
It's just an interesting finding. More data is needed. We got to be careful, and I don't want to run into Will's time. But I think that ER and HER2 are really robust targets, and we would love to see a study looking at using imaging to help find those targets and using some sort of high HER2 marker to follow that.
And then finally, this was a pilot study looking at ctDNA with FDG and FES PET. And we did find an association between the ctDNA fraction. This was low pass ctDNA, so looking at copy number variation and other markers that we can determine through low pass sequencing or low pass molecular analysis. There was an association between that fraction and the number of FDG lesions and the extent of FES avid disease, so the total lesion uptake. So I, with that, will step aside and allow Will to take over.
All right, thank you. Let me pull up my slides here. So I'm going to really focus a bit more on the updates to the DESTINY-02 and DESTINY-03 studies of trastuzumab deruxtecan, and then also maybe take a couple of minutes for us to think about, particularly around the ILD monitoring, what sort of makes sense with what the trial did and kind of what we can really feasibly do from a clinical standpoint. And then we'll finish up talking about the results from our phase 1 adjuvant Walkabout vaccine, which we presented as well. So the DESTINY-Breast02 study, phase 3 multi-center trial for really one of the earlier, obviously, DESTINY studies in individuals who had previously received first-line therapy as well as TDM1 in the second line, at least TDM1 in the second line therapy. And then these individuals were then randomized to receive TDXD versus treatment of physician choice. It was really sort of capecitabine plus trastuzumab versus capecitabine versus lapatinib. This was before tucatinib was an option, which certainly one would consider here now. When we look at the demographics, I think one of the more striking is that these individuals the vast majority had received at least 2 prior lines of therapy in the metastatic setting, and really 30–40% had received 3 or more lines. So really fairly heavily pretreated population. When we look at now the updated progression-free survival, again, continues to see what we've seen before now with a median progression-free survival of 17.8 months for the trastuzumab deruxtecan versus 6.9 months with either the capecitabine trastuzumab or capecitabine lapatinib. So pretty a robust difference between those two, suggesting at least more clinical benefit with the trastuzumab deruxtecan. This also plays out in the overall survival follow-up, with median overall survival at 39 months for the TDXD arm versus 26 months for, again, the treatment of physician choice. So really kind of shows a pretty wide difference from a kind of clinical and efficacy standpoint. When we think about the side effects and the side effect profile, Not really any new signals from the BREAST-02 study, in the most common side effects being nausea, sort of GI side effects. I think certainly the cytopenias are something that we also are appreciating as sometimes a potential challenge. The ILD obviously is what always has been grabbing and should continue to grab our attention in regards to this agent. We look at the incidence of adjudicated drug-induced ILD. And so this adjudication is essentially they have a group of pulmonologists and radiologists and so forth who review all the imaging and imaging that may indicate ILD. And then they review and make sure there's no obvious other cause, such as infection and so forth. So these are the adjudicated ILDs in the study. And in the TDXD arm, certainly the vast majority of these are grade 1 and 2. There were 3 grade 3s, but obviously most concerningly, there were still 2 grade 5s. So 2 individuals did die from this. The range and the incidence was again right around 10%. You know, I think we look across the Destiny Breast-03 and Destiny Breast-04, I think we're probably seeing at least 10% incidence and probably closer sometimes to 15%. A little bit of incidence of this in the TPC arm, but this definitely seems to be kind of more of a driver, as we have been aware for a while for trastuzumab deruxtecan. So then thinking about, so the next level or the next clinical trial in the Destiny course of trials, we have the Breast-03, which really sort of has established TDXD as our now second line therapy in folks who have received prior trastuzumab and taxane in the metastatic setting. In this study, individuals were then randomized to receive TDXD versus TDM1, which had really been our second line therapy. And we really see, again, a very robust improvement in progression-free survival with a median PFS of 28 months with the TDXD arm versus 6.8 months with the TDM1 arm. So almost over 20-month difference in the two. We look at the overall survival, not reached in either arm, but do again see separation of these curves and suggestion that the TDXD does seem to infer better long-term clinical benefit as well. When we look at the side effects also from the Breast-03, again, similar to what we've seen previously with some cytopenias, GI side effects, particularly around nausea, vomiting, and then when we look at, again, the ILD here, again, seeing a bit of a higher incidence of ILD. Again, the vast majority is still being the grade 1 and 2, but they did have 2 grade 3 with a total incidence of around 15%. This did increase compared to the original presentation of the Breast-03 when the incidence of pneumonitis ILD was around 10.5%, so it's increased to 15%. But again, majority of these were grade 1 and 2. Now TDM1 certainly does also have some ILD, with the majority also being in the grade 1 and 2, but I think we don't really tend to think of that as big as sort of a threat as what we're seeing with the TDXD. So, you know, this was a summary by Dr. Telly, and I think it's a fair representation of how we're thinking about sequencing now in the metastatic HER2 breast cancer space, you know, with your taxane and HER2-directed antibodies as your first line, then followed by maintenance, TRAS-per2s with or without endocrine therapy based on the phenotype of the breast cancer. But then second line, probably tended to lean more toward the TDXD, though we've not really compared it head-to-head yet against tucatinib. Certainly considering tucatinib-based strategies for brain metastasis, but there's also growing data now for trastuzumab deruxtecan to also have some CNS activity. So I think, you know, from the Tuxedo trial, we've seen some of that, and we have ongoing studies sort of investigating that. So we do think there is, you know, likely CNS activity there. You know, now I think it's becoming a bit more challenging. I think after you get past tucatinib, what do we do next? I think probably that's the space for TDM1, but then in later lines, you're thinking inclusion of margetuximab, possibly neratinib, different combinations of chemotherapy plus HER2-directed therapy as kind of your later line options. So after kind of discussing this and thinking about kind of the clinical activity, I think there's also certainly the more sobering discussion of how do we think about kind of the ILD and sort of monitoring this. And I was hoping that this could allow sort of kind of a discussion with the group in general. If we look at the Destiny trials, and this was certainly early appreciated in the Destiny-01 study, this incidence of ILD. And so in the Destiny trials, they were essentially performing surveillance CT chest every 6 weeks, which is obviously much more frequently than we would be typically doing. Certainly the advantage of that is that, potentially they can capture subclinical ILD before it's symptomatic, i.e. capturing them potentially in a grade 1 side effect profile that you can manage with holding dose, reducing dose, and even with a short steroid, but could potentially even re-challenge with TDXD, whereas when you're in the sort of the grade 2 or higher, you really can't, based on what we know now, re-challenge with TDXD. I think certainly the challenges of that more intensive therapy, I mean, they paid for it on the study, but in the real world, I don't know that we're going to get insurance coverage to cover Q6 weekly scans. And certainly, as we're doing scans, that's cost, that's the anxiety of scans, that's the time burden, time away from work and family, doing kind of twice as many scans as we probably would be normally. So, there's been some suggestion of, well, possibly thinking about Q9 weekly scans. So I'm hoping to sort of bring this up as sort of a group discussion, but then also talk a little bit about sort of some of the guidelines that are also out there right now, such as the Sandra Swain article, thinking about kind of the management of the ILD. But I'll come back to that. But I was sort of hoping to open it up to the group to think about, how should we be thinking about, or what's the comfort level in increasing frequency of CT scans for this monitoring? Is anyone doing that yet? And so kind of wanted to open that up for everyone to sort of discuss. Maybe I will.
I think the deal with the trial, Will, was that they were monitoring disease. So they were getting the scans at that frequency for disease. And while they were at it, they took a close look at interstitial pneumonia issues, educated them, and aggressively acted. And I think what Sarah presented was a very aggressive monitoring strategy, because she feels terrible that people can die from interstitial pneumonitis. And so I think we're trapped a little bit. And what we're all doing is monitoring probably less frequently. We're not overreading the interstitial issues, and we're getting O2 sats every time the patient is seen, and warning the patient that if they feel short of breath or if they have a cough, we want to hear from them. And I don't know what the right thing to do is here. Surely it's not that for the rest of their life on TDXT they get a scan every 6, a non-con CT. But there's got to be sort of something in between.
Yep. Yeah. And I think the original incidence was in the first 2 months, but as we've gotten more kind of data, it does seem to be stretching out. For the median incidence of the ILD can go out to 6 and even a year. So it beyond that, we probably don't have a ton of data. But right, so the duration, if we're going to increase the frequency, what duration? Because this surely should not be for lifelong. And I'm sorry, I interrupted.
Yeah. No, Will, I wish I had something really wise to say here, but I think this continues to be a real challenge. One of the other things I see is that you mentioned scanxiety, and that is an absolutely real finding. I also have a little bit of trepidation, not based on our radiology colleagues, but every time you do a scan, it feels like there's other incidental findings. And I I think it would require some very close collaboration with body imaging and chest imaging to try to make it very clear of what we're looking for, so that we're not. I worry about actually stopping really effective therapy too soon, and maybe it's because I haven't blessedly had the experience of someone having severe toxicity, but I also have some concerns about, seeing a little bit of a non-specific finding and then feeling like you have to stop an effective therapy. So
Yep.
It's challenging. I mean, I think maybe coming up with some sort of plan that we feel comfortable with and asking for guidance from pulmonary and from our chest radiologist to see if we can strategize so that the person reading it knows exactly why we're doing it, to try to avoid both overcalls and undercalls.
Yep. Yeah, no, absolutely. And I unfortunately have had a second opinion who unfortunately did not have a good outcome when having this. And so I think I'm a little bit hyper aware of it now as well. So yeah, I think it's sort of an ongoing discussion to think about what makes the most sense, but appreciating the very real challenges of increasing scan frequency.
Well, did they do any correlation of symptomatology with what they saw on scans? I mean, I guess I'm just wondering if people are having symptoms that correlate with that, or if these are radiographic findings only, or.
No, she was clearly trying to get at something that was only radiologically apparent. What she was really aiming at was something that's actually quite subtle. And so that's why Jen is nervous, is because those subtle things might not be real. The one thing that was made very clear to me, and that I feel like we all need to agree about, is if the patient has interstitial pneumonitis from TDXD, they should not be rechallenged with the drug. And I think we can be very clear about that issue. I think that the other stuff is much harder. But I think what the team conducting the study was getting at is maybe if we're just super aggressive, we can nip this in the bud and you can get the steroids started and the really bad complications won't happen. But I'm not sure we're there yet.
Yep. Yeah. And I think that's some of this. And so thinking about, certainly for the grade 2, 3, and 4, but for those folks who essentially just have radiographic findings, I think that's part of why, again, what they were looking for is could they capture them super early? And yeah, as to Jen's point, I mean, they may have been treating ILD that was never going to manifest anything beyond that, or they may have been treating something that wasn't ILD as a grade 1 because they were asymptomatic. So all the grade 1s weren't having any symptoms. So this is, I think, kind of a nice, at least, review article of what we know to date from Sandra Swain and colleagues that was published about a year ago for ILD treatment management. Certainly this is a very aggressive approach, but I think in general, the take-homes are, utilizing CT imaging when you are of concern, so new respiratory symptoms involving pulmonary early, and then frequently thinking about introducing steroids and holding the drug. I think the challenge, and to again go to Jen's point, I mean, we see the clinical activity of this, and so I think utilizing being very cautious of not losing a very effective therapy, but also being cautious that we're not sort of increasing safety issues. So lastly, I'll talk about our adjuvant vaccine study. So this is a study that thank you all in regards to referring patients to, and I just lost the lights here. But this was a adjuvant dose escalation study of our plasma DNA vaccine WalkVac. It encodes sequences encoding 3 proteins that are associated with higher risk of recurrence, HER2 being one of them. So it's HER2, IGF-BP2, and IGF-1R. And the way this vaccine was constructed is it pulls out peptide sequences that really elicit a strong anti-tumor immune response that we term a Th1 response. And so pulling out those very specific immunogenic peptide sequences of IGF-BP2, HER2, and IGF-1R. And then this is mixed with GM-CSF, which sort of acts as an immune adjuvant with the WalkVac vaccine. So in this phase 1 dose escalation trial, we were enrolling patients who actually were HER2 negative. So these were obviously your hormone receptor positive and triple negative at least had to have also lymph node positive disease and completed their therapy. They could be getting concurrent anti-estrogen therapy. The 3 dose levels were 150 milligram, 150 microgram, 300 microgram, 600 microgram with 10 patients per dose. And its primary endpoints being safety of the doses and then immunogenicity. When we look at safety, it's very similar to the safety we've seen with prior vaccine studies. The vast majority of our adverse events, really all of the adverse events are grade 1 and 2, with the vast majority being essentially local injection site reactions and sort of systemic flu-like symptoms, but no grade 3 or higher adverse events. We look at the immunogenicity of the different doses. We see that all the doses were able to elicit immune responses to at least one of the targeted peptides. The greatest, interestingly, the greatest immune response from the T cells actually seemed to be to that intermediate dose of the 300 micrograms. So 80% of those patients actually retained that immune response at our sort of intermediate and long-term follow-up at 1 and 6 months post-vaccination. So it really seems like the most immunogenic dose versus the lower and higher. Again, in sort of a different way, highlighting that when we think about immunotherapy, maximal tolerated dose is not always going to be necessarily the best dose. These again, we enrolled hormone receptor positive and triple negative, but the majority of these folks were hormone receptor positive, and we're continuing to follow them in regards to sort of long-term outcomes, and that will be presented in the future. So it's about 2 more minutes, but certainly can open things up for further discussion.
To go back to the Enhertu ILD thing, this is Amy. I was wondering if they mentioned anything about renal toxicity as a risk factor or stratification factor, because there's like a little note in the package insert about renal impairment generically being linked to more grade 1 to 2 ILD.
Yeah, I have actually also seen that when looking at the side effects in the package insert, but I don't know that I recall them mentioning that in these abstracts or presentations, but that's something that I've also noticed. Not sure that I'm aware of the physiology of the relationship.
Me neither. It's not like readily cleared or anything, so I was just curious if they had talked about it.
Some of the mechanisms that they think may be mediating the ILD may be sort of uptake by actually immune cells within the lungs. Is sort of one potential mechanism, but it still kind of remains unclear, but that obviously would not have to do with sort of the renal function.
I think what you're really getting at there is, is it dose related? And we are actually trying to ask them that question. But that's really, I think, what this is all about is, if the clearance isn't as good, then maybe you're getting too big a dose.
Right, for sure.
Oh, thanks.
All right. Well, thanks, everyone.